Welcome everyone to the seminar on practice problems. This is a key initiative of the M&SOM journal's practice platform. And the goal is to bring the voice of the practitioner close to the operations management community to inspire and facilitate new and exciting operations management problems that are relevant and impactful to practice. And today we welcome Dr. Steve Miff, who is the CEO of the Parkland Center for Clinical Innovation, PCCI, to share his insights on AI development and deployment at the in clinical decision support and population health. We also are today, along with the department editors, Georgia Perakis, Anand, Jeremy, and myself, we invite Professor Vishal Ahuja, who is a faculty at the SMU Cox School of Business, and whose research focuses on a various aspects of healthcare delivery. And Vishal will also co-host this seminar that we have today. And this seminar, just to remind everyone, it's going to be recorded and it'll be posted on the M&SOM's YouTube channel, so people can view it later. And the journal also allows people to ask questions and comments through the channel, and it'll be moderated by the editors for a month after the event. And I'll hand it over to Vishal to introduce the speaker and help moderate this session. And thank you, Steve. Thank you, Vishal.
Thank you, Pavitra. Good to see so many of you, some familiar names. Thank you all for joining. I want to thank Georgia for this initiative, Michelle for moderating it, or rather facilitating it, and Pavitra, Anand, and Jeremy for the opportunity actually to help bring this talk. I want to introduce Steve first. I mean, he's a dear friend and an expert in all things that involves data analytics, AI, when it comes to healthcare. So it's my distinct honor to present Steve Miff to this seminar. He's the CEO of PCCI, as Pavitra mentioned. PCCI is a leading non-profit artificial intelligence and cognitive computing organization affiliated with Parkland Health, one of the country's largest and most progressive safety net hospitals. Now, for those of you who may not know about Parkland Health, just give you one tidbit, which is this is the hospital where JFK was taken after he was shot back in the 60s. Now, Steve's got a lot of skills, but he's passionate about using next-gen analytics and technology to help serve the most vulnerable and underserved residents. His team focuses on leveraging technology, data science, and clinical expertise to obtain unique social determinants of health data and incorporate those holistic personal insights and point-of-care interventions. You can read a lot more about PCC and all the awards they have won, but a bit about Steve himself. He has won, I can't even count how many awards, but I'll give you some examples. He was named from the 2020 to 2023 Dallas 500 Most Influential Leaders. He was named the Tech Titans Emerging Company CEO of the Year. He's a recipient of the 2022 Corporate Citizenship Award. And most recently, which is this year, like last month, he was named on the top AI 75 list, the Healthcare Hero and AI Impact Innovator. Steve bleeds purple. He's got 3 degrees from Northwestern, an undergraduate, as well as a PhD and MS degrees in biomedical engineering. And he's also an adjunct professor of biomedical engineering. He's actually co-authored a book that you can get on Amazon. Without further ado, I'll pass on to Steve, but one logistics thing. Please feel free to ask questions during the talk. Put it in either chat or raise your hand, and me along with our 3 platform editors will help moderate as well. And we'll leave ample time for questions in the end as well. But again, feel free to interrupt. Steve does have a hard stop at 11:30 Eastern, 10:30 Central. Steve, the floor is yours.
Well, thank you so much for the kind introductions, and thank you for having me. Just very excited to not only share some of the work that we've done, but interact with all of you and just brainstorm we can also take this next. So the title that I put for this, it's a bit provocative. You know, can AI save lives? And want to say from the beginning, it's people that save lives. AI can help people, particularly where we are today, and the AI spectrum. It's so broad. Where I believe, and the examples that I share with you, the biggest impact that AI can have is in decision support and augment the decisions that frontline clinicians and physicians make. And that's sort of the examples that I want to share with you and walk you through a couple examples of the journey of a AI lifecycle, and how and what are the learnings from both development and deployment. What are some of the things that needed to be adjusted, and how you continue to evolve and support some of these models that are equally important. So that's the plan. As Vishal said, please chime in with questions. I'll purposefully pause at a couple points throughout, but Vishal, please feel free to interrupt at any point as the questions come in. You've already done such an amazing job introducing PCCI. One of the things that I want to use this is sort of just highlight sort of the pool of examples I'm gonna pull from. And what I'm not going to talk much about this today. To be able to do this type of work, it requires a digital data environment that goes beyond what organizations, traditionally have in their electronic medical record or into their data warehouses. To be able to bring together multiple data sets, to be able to merge those data, to merge that information in a way that we have a more holistic view of that individual, not only from their physical health, but equally important from their mental health, information about their life and the environment where they live. The information about, SDOH, social determinants of health, or call them the non-medical drivers of health. And then also increasingly, how do we better understand the individual and their family's capacity for self-care? All of these, we believe, are so important, and in different aspects, it required to be integrated to be able to understand the person better. And that's the information that can be used to create better algorithms to be able to identify rising risk and tee those up to frontline staff and clinicians and physicians in a way that's useful. And again, augments the decision they're able to make and speeds up or help them make the decisions earlier in their whole disease progression cycle. The work that we've done sort of falls into a couple categories. Again, the whole purpose is around how do we actually able to bring information together to augment what clinicians already see. Some are at the point of care around the clinical decision support. I will spend some time on the trauma model, but there's several others that we've been working on. The other one is more of the population health. How do we proactively identify rising risk in certain populations and be able to interact with both individuals that are at risk and alert providers of those events, so interventions can happen earlier. And then a whole bolus of work around how do we actually use this data to better understand the individuals and to do that at scale. And then how do we use this data to be able to create those connected communities, because healthcare providers can only take this so far. But again, I strongly believe that health doesn't start in our healthcare facilities. It actually starts where people live, learn, work, pray. So that's why that's so important to have as well. So just want to position this before we get into a couple examples. One of the other thing that is so important for any organization, this is something that we've been spending a lot of time with our colleagues at Parkland on, is to really understand and map out and manage the full life cycle of AI or any other algorithms. That it always needs to start with the problem. It always needs to understand what is the true clinical problem that we're trying to solve, and then decide, is there a way that these algorithms can enhance and help solve that problem, bring information in new ways, bring information in a way that helps clinicians to address that better. So that business case, it's a critical component to be able to first evaluate. there's a review by a multi-stakeholder approach. It's not only the clinicians that need to be part of from day one through the whole cycle, because ultimately they're the ones that use these algorithms the way they find it useful. But it's the IT teams, it's the ethics teams, it's the various parts of the organizations that need to be part of this in order to make sure that these are not only used in an effective way, in a useful way, but they're used ethically, they're used responsibly, and there are checks and balances in place to ensure that that's being done well. This, this starts even before you get to do any of the, the fun and sexy work. And before you even get to do that, you need to bring in the data, because if we've learned, over the centuries, is for whatever you use, if we use a simple Excel spreadsheet, right? Junk in, junk out. The wrong data, produces the wrong outputs. So I can tell you that in most of the work that we do, we probably spend 80% of the time on the data staging and curating the data, validating, understanding missing values, merging data, ensuring the quality of the data. And then you get to actually do and build the algorithms that use the various statistical models and approaches and sort of to build those AI. And once you build them, you need to go through and validate it, right? Particularly if it's something that comes from an external source, or those algorithms are generating externally. Does it actually perform the way that you intended to perform for the population that you're applying this towards? Because it could vary. You want to be able to validate that it performs the way that you expect it to. And in many cases, you might need to retrain those models to be able to be representative of the population that you're trying to influence. The deployment is actually a fairly complex process, because once you integrate it into various workflows, you need to deploy in a way where it's useful and accessible. And you need to deploy in a way that can be supported. And then once you get through that whole cycle, you need to constantly monitor it, because you want to make sure that in some of these are self-learning, so adjusts based on the new data that comes in all the time. You want to make sure that it continues to perform the way you intended it to. So anyway, I wanted to spend a little bit of time on this before we go into the examples, because without this, it's really difficult to build something that not only it's useful and effective, but ensuring that it's ethical, it's equitable, to ensure that it's sustainable. That's what I think is so important. And this takes time. It takes people. It takes processes. And that's where I think so many organizations need to spend time to stand up these components before you even talk about the technology or the data itself. The Health AI partnership that was started by Duke for a really good resource on this. PCCI has been one of the inaugural members, and the privilege of spending quite a bit of time with that. Actually put forth some really good guidelines about the full life cycle of AI management and some of the governance models. So Google that, Health AI partnership, to learn more. That puts a lot of these available to everybody. All right, so let's make it real. Let's go through a couple examples, and I picked one that's more that point of care decision support, and then this is on trauma and mortality. The other one is on population health, and we're going to focus on pediatric asthma. So that's sort of that's where we go. So we'll start with the Parkland Trauma Index of Mortality. Why is the problem? A little bit of a background, and where sort of the this type of algorithms, this type of AI can help. One, Parkland is one of last year the busiest emergency department in the country. Over 250,000 emergency department visits per year. A trauma 1 level center, so the most complex, complicated trauma, it's oftentimes brought here from a much broader geography. By being that busy, as you can probably imagine, and sometimes what you see on TV shows, mirrors reality. One of the things that it does is that it is busy, it is chaotic. you have people that have been in a severe car accident to people that are there with the flu. So trying to triage to that many individuals and then trying to take not just one, but probably any time, half a dozen to a dozen extremely complex individuals at different stages of where they've arrived. It's complex. And think about just the data that's being generated every single minute, every single second on each of those severe trauma patients, because you're constantly running diagnostics, you're constantly running labs, you're constantly updating tissue imaging studies. All that information comes real time and it's being updated. How would a physician or a group of a clinical team able to synthesize all that information and predict and anticipate who do I need to spend more time on when something new comes in, a new lab, new text? The critical decision that's trying to be made here is how much more do I need to stabilize this individual before it's safe to take them to the operating room? There's a very critical point in time that clinicians are juggling all this information and trying to say, because the goal is to take that individual to the operating room as fast as possible, because that improves outcomes longer term. But if you take that individual too fast to the operating room, they could expire either on the way or while they're being operated on. A lot of this is based on experience. It sort of synthesizes all this data. If you talk to frontline clinicians in the emergency department, that's what it's based on experience. Take not just one individual, again, take a dozen, half a dozens that are having concurrently. This is how do you make sense of all this information? How do you make sense when their shift changes, right? Where you try to translate knowledge from the physician that's been with this patient for the 12 hours and now there's a new physician coming in. How do you communicate between the emergency department staff, the OR staff, the ICU staff? So you're not only looking at the same data, but you interpret it the same way. So I spent a lot of time kind of painting the picture view because this is challenging, right? So that's where algorithms, that's where synthesizing all this information, making sense of it, teeing back up for a provider to use the way they're clinically trained, it's critical. This is what this Parkland Trauma Index for Mortality model is aiming to do. One of the things that we discussed, there's a, yes, absolutely, I'll pause.
So a couple of things here. Anand posed a question, and you may be able to answer it as you explain the PTI model. But Anand says, there's the algorithm you mentioned, which might be the more glamorous side of things, and then data, the cleaning, getting the right data source. That's sort of where the devil lies in the details, right? Then you add on the fact that there's a context, the circumstances, the organization, the society. And do we understand? Are we on the same page with the problem? And I think what Anant would like to know is what is the optimal percentage of time that should be spent on algorithm development and testing?
I don't know if there is a simple answer to that. Here's why. It depends on how much data you have to work with. In this case, the development of these models took 5+ years because mortality, people dying doesn't happen that often, which is a really good thing, right? So when you're trying to predict, that you're working with a much smaller data set. So the amount of data that you have, makes a difference on how long you actually need to spend in not only the developing, but then testing those models. The other components, like how many different data sources you need to integrate to be able to, the more data you integrate, obviously, the more complex that staging and all that that happen. So again, in this case, and I'll highlight that more details in a second. It took a tremendous amount of time because there are multiple stages to this. One, I mentioned sort of the curation there, but before that even happens, you do the literature search. Some of these problems, they're not new problems, just, there's a new way to try to bring information to help inform them. So there's a vast amount of knowledge that the clinical teams have, that they're metrics that they're already looking at. Well, you absolutely want to incorporate those because you don't want to leave out something that they clinically determine that's important. You go way beyond that because you also want to find things, others that are very correlated to be able to predict a certain problem, and then you vet those. You build, and that's the approach that we take, you build a model using retrospective data. Again, sometimes you need to have 5 years worth of data. Sometimes you need to have 10. It depends on the data size and what you're trying to predict. Once you have a model, then that's where you test the model. You understand how it performs. You have the conversations with the clinicians to understand what goes into it, et cetera, to make sure that not only they're relevant metrics, but actually things that are actionable that you can do something about. Then we actually run those in silent mode. Once we determine that this is something that works, you run it on real data, but what silent mode means is it predicts, but you're not making clinical decisions on them. You're not actually teeing it up where it becomes part of the decision-making process. So that's an important step because you're actually using it not only to see how it performs real time with real data, you use the time to also build how you're going to incorporate this into their workflow, how you're going to display it, what are some of those things. And then you actually, decide that, okay, after X amount of time that you determine, again, it varies depending on how much data you're able to churn through, that you're going to go live. When you go live, you stage it. You don't go live with everybody. You go live with a subset of the clinicians. So you go live with a department within that organization, and then you start to scale up, and then you start to monitor. So it's a long and somewhat complex answer to that question, but I think it's such a relevant question because this takes time, and it needs to be pretty prescriptive of how you do it to make sure that you do it right. You have all these different steps along the way.
Thank you,
So
Steve.
hopefully that provides some good.
I want to pivot and kind of build on this and kind of help me understand a little bit better, or for the audience. I emphasize for the PTIM, maybe it'll become more apparent, the model. As far as I understand, there's not a single level 1 trauma center that has anything of this sort, meaning they don't have a methodical way of understanding. And part of it is, which you've highlighted before, one, of course, there's not enough data, but also the time, the window in which you have to make a decision is just so short, and everyone's rushing. There's multiple teams that need to be coordinated. So I just want to kind of emphasize that part.
You're so spot on, and hopefully through the next couple slides, I'll make that real. You're right. This doesn't exist anywhere. This is the first of its kind and the only one that's currently actively being used. Something that folks have used for a long time is this, Glasgow coma score. It's something that it's well known. It's manual. It's something that you do once and then you move on. So certainly wanted to incorporate that because it's standard of care. And then, I'm just highlighting here some of the, top variables that are in the model important. Obviously, many more, but these are the ones that rose to the top as the model was built. And this gets probably a little bit too in the weeds, too clinical, but I think it's important to kind of see the type of information that some of these models require. So that's what I wanted to put out there so you can see information that is being already collected. Right? It's information that exists in the electronic medical record. Sometimes it's all over the place, right? So it's not all in one place, but it's information that's used. It's important. Here again, I'll go back to how do you synthesize this? How do you bring it together in a way that augments that decision that a clinician makes? A bit about kind of going back to one another question was, model was trained in about 2,000 trauma patients, 2009, 2014, tested on a subgroup of this 516 patients. Sort of this was the the silent testing once you kind of sort of build the model. Just a little bit about what type of model and the approach that we took from this perspective. You know, I'm not going to go into details, but those that would like to spend some time a bit more on the actual nuances of the model here, sort of some of the statistical parameters. A couple of things, Vishal, you mentioned this. I think it's important. Sort of what's the window, right? So again, this was done very much in conjunctions with the clinicians, where we do not do this in the first 11 hours because there is a activation that needs to happen. The baseline information needs to be collected in order to have that information available to start to be able to do the prediction. You know, and it predicts then every hour over the next 48 hours. This is the window where those critical decisions need to be made about what else do I need to do, stabilize the patient, is the patient ready to go to the operating room, all those different things. So very purposeful on what is the window that you're actually using the data to predict. How do you give yourself enough time to have the data so you don't start predicting where you have missing information? Because then again, from a quality perspective, you want to make sure that it's robust. So this sort of schematically sort of shows you prediction window, and then when the actual decision is, obviously you go beyond so you can actually do that. So this hopefully puts a little bit of the timing component that you talked about. The other type that I mentioned, once you actually have something that really works, where do you put it and how do you actually use it? If you do not able to put it where the physicians and clinicians already do their work, it's not going to be effective. Also, on the patient page in Epic or any other electronic medical record, this is the most expensive real estate, that electronic real estate you have. So it's got to be something that's really important if it's going to be deemed that is going to make it here. PTIM is, you know, you can see sort of representative. It's now one of the key things that's being displayed on that on that page, because the physicians, they're the ones that say, hey, this is really important. We want this. And it's got hover functionality, so you can see, you know, exactly gives you more more details about it. One of the other thing is also, it's not only on the summary page, it got its own tab. So that's another really important part, because you get the summary page, it's on the summary page, and then you have all the other really critical things that physicians decided, this is something important that we want to look at. It's not the only one, it's alongside all the other things that they already use. So again, you want to make it easy, put it somewhere where they're already using it. One of the other things that, and this is really important for AI in general, and is it's great to be able to give a score and then know what that score means, have the interpretation of what do I do, X, Y, and Z. But where AI needs to go, and in this case, we've been able to proactively do it, you need to be able to give insights beyond and behind that score. You need to be able to see what is driving that score, to be able to see the history of how it's evolved, to be able to get quickly to that actual data that's driving that, because that not only gives transparency to the user, which is really important, it's not a black box, but also starts to guide what actions and where do I need to take to be able to impact that. So in this case, if you click either on the score or go to the tab, you get a one-page summary that's been built that real time pulls the information of that score, as well as the information of all the data that's contributing to that model. This is small, but wanted to show that it's in one page so you can, you can see it. I pulled in a couple other screenshots that kind of just gives you a little bit things, just because I want to highlight a couple things. It's really important, and that's why we do it everywhere, that, that everybody that looks at this knows that it's not a substitute for clinical judgment. It just brings information together. It's the real information, but it just creates, what is it? What is the window that it predicts? What is the assesses? And it's just like, look, this is just meant to augment. It's not, you're the one that makes the clinical decision. This is, sort of important because, need to be transparent on how to use it. Is the score itself color-coded if it's in the green or red. This is, again, the thresholds determined by the physician. It gives you a sense of how it's changed in the last hour, and then dynamically picks what are, at that point in time, the top metrics that are driving the prediction. So in this case, you kind of see what they are. In this case, by the way, this is made up. I mean, it's not made up of blinded data, but so I'm not sharing any PHI. If scroll a little bit further down the page, you actually see the history of the PTIM score. So early on, it was in the red, above 50, which is risk. Below, if you hover at any point in time on any of these, you see the values of those top predictors there are above, because you want to be able to sometimes see how those predictors have changed. And then for each of those metrics, you see the actual data and the table below, and you see the whole historical information. So this is sort of important because, again, it's curating and bringing the actual data, synthesize it, organize it, create it into a predictive algorithm to make sense of it that's been validated, tested, clinician understood and approved, and that's become something that becomes useful, becomes something that it's being used now for a couple of years in real time in the busiest emergency department in the country.
Steve.
So let me pause for a second. I want to go to the second example, but I'll pause for a second here, and then we'll touch on one more.
So Steve, we have a few questions in the chat. Anant had asked how many person years when you're developing the PTI model, what part was algorithm development and testing? I think there was a slide that talked 1935 patients over a course of a few years and then 516. So
Correct.
Hopefully, Anant, that question was answered there. Pavitra asked, how do you check how good is the model? I'm guessing that's the fidelity of the model.
Yeah, so that's where I put some of the, early on, I put some of the both statistical parameters and as well as sort of, again, some of the prediction, the actual, some of the numbers. So that's, yeah, so that'll be a good thing to sort of review and look at for that question.
Another question is, do you find that trauma surgeons are already adept at assessing risk of death, possibly better than the model? And are they the right users or perhaps junior staff?
So we've had many conversations on this with the trauma surgeons, the OR staff. The head of trauma surgery, Dr. Starr, has been the clinical champion for this and one of the most, if not national, international renowned trauma surgeons. So are clinicians very good at it? Yes, it depends what level of expertise. So a resident versus a junior clinician versus an experienced physician, just like in anything else, certainly varies. And he would tell you this, that decision about, is this patient ready to go to the OR? Is it not ready? It's very much of thumbs up and thumbs down. Yep, it's ready right now. It's based on that experience. It's based on sort of synthesizing all that information in my head. What else he'll tell you is that they're not always in agreement between the trauma surgeons and the OR ICU staff. And he tells the story, I'm only repeating it, that literally they used to have screaming matches, about it's ready, no, let's go. And there's like, no, it's not ready, and they're all looking the same data, but using this. Since this has been deployed, because this was done in collaboration between the two multiple sides, they don't have those conversations. They've agreed. Scores over 50, patients ready to go. Scores under 50, we need to get it over 50 because otherwise, patient's not going to do well. So now they're using, because they've been part of it. They're the ones that guide it. They have transparency behind it. So that's something that I think it's really, really important. And again, it's like, tease up, why and how this is useful.
I'm glad you brought that up, because I was going to say, for those of us who do behavioral ops work, getting that aligned strategy was one of the key components. You mentioned Starr. You also should mention that Dr. Caroline Park has been a junior who's much more tech savvy, and she's been the driver of many of this implementation. They're actually looking at
Absolutely.
right now as an option how to implement it with the huge success, and STAR's been going around. So this idea of behavioral nudges on like, look, we're all in the same alignment, that's been a great. A couple of other.
No, you're absolutely right. That part just equally the two of them from both sides, looking at it from their own perspective, been just so critical.
We've kind of somewhat answered the question, but we'll take two more. Jeremy asked, what's been the impact of this implementation of this model? We talked about alignment and whatnot. Are there any clinical numbers you could share in terms of improvement of outcomes or whatnot?
Yeah, and this is a particular. So we've published some papers. I'm be happy to share those. And I'll have very tangible outcome and ROI studies for asthma. This one's harder. Here's why. You predicting somebody actually the risk of dying and the action to be taken. You're doing this because you're trying to actually prevent, those adverse events and death. So, and you saw the numbers, that the numbers are not large to begin with. So anything that you're trying to predict early on that you've sort of intervened, same with sepsis, if you think about it, there's a risk of somebody developing sepsis here, the risk that X, Y, and Z, because this person is at higher risk. The goal is to take intervention earlier than you've ever done before. By doing that, are you actually preventing it? Well, yes. So we're in the process of trying to actually work with and deploy this at other systems, so the number increases. So when you do a more robust outcome study, it's much more informative and is statistically significant. The one thing, though, I know that sort of, to me, it's also, are people actually using it? All right. And, we knew that this works when literally it was 2 weeks into the go live, and it was a Saturday morning, and Dr. Starr actually texted our team and said, hey, does the algorithm take the weekend off? Well, as much as he's like, has a great sense of humor, it stopped working. So one good thing about it was, hey, he was looking at it, on a Saturday morning when he was in, and he cared enough that he's like, hey, where is it? To me, that's a very important piece. The other part is that it was not working, and kind of gets into the whole management process post go live. Oftentimes the algorithms themselves, they don't break. Now they might drift, so that's why you constantly need to evaluate it. What breaks is the input points. So there's like an update on an Epic module that was done that prevented one of the key data points to come in. Well, if data point stops coming in, the algorithm doesn't produce anymore. So that's why it takes a whole team of different parts of the organization when you deploy something like this to be able to monitor and react quickly. Because once people use it, even though it's just meant to augment their decision, it's something that if it's useful, they want to use it more. If it's just like any other data point, if it's something that that you want to need, so that's an important part. Sure.
One more question. You kind of addressed it somewhat. Is there a risk associated with it, and how's been the doctor's reception of this? We've kind of addressed some of that, but if you want to add something.
Yeah, the only thing I would add is, again, I think it's extremely important to be very transparent. Ultimately, the decision for anything that's being made resides with that physician, with that clinical team. This helps inform the decision. You saw the tab at the top. This is one of, half a dozen other things that they're looking at. It brings together the information they're looking at, synthesizes it. I think it's the other part that I'll say, it's really important to have the transparency behind it. It's not a black box. Also, it's really important that they determine what those thresholds are. So again, this is not something that sort of just a bunch of data scientists sat in a room and developed. It's like, hey, here it is. The clinical teams have been intimately involved at every step of the process. They know what's going in. They know what's coming out. They make the decision, even sort of what are those thresholds. they want and the actions that they want to take. So all of those, I think, are really important. And that's what then you use it with the right purpose within the right context.
Any liability issues you think potentially?
I mean, no more than anything else. That anything. Again, it's data that resides right there. I mean, how is this different than a BPA, best practice alert, right? I mean, it's much more sophisticated math and algorithms, but it's just still an algorithm of math that one triggers a, hey, go see this patient. This one says, go pay attention to this patient. Here's why. It's just.
Yeah, and I mean, nothing different than Dexcom's glucose monitoring meter. I mean, that's
right. It goes over a threshold, or your Apple Watch say, hey, like mine just did, stand up because you haven't done anything. Well, it measured that I didn't stand up and tell me to stand up. Well, it's my decision whether I can. Right now, I probably shouldn't stand up, but right. So it's just now obviously much more involved, but same concept there. So I think when we think about ethical applications of AI where we are, this is to me an approach that addresses a lot of those things in a very thoughtful and very process-oriented way.
Right. And one last thing, I think it's important for people to mention because it's so much practical implementation, the importance of dashboarding, the importance of having that big score. You want to emphasize how much time went into making sure the dashboard is right. And this is across corporations, not just healthcare, because you have only 2 seconds to look at what the score is and have an alignment. There's a lot of work that put in the design of the dashboard as well.
Oh, incredible amount of work. And think about that, sort of it's real-time data, right? That comes in and needs to be, accurate. It needs to be visually, again, you scan it, you need to be able to make a decision. And it needs to be somebody, it cannot be like, 4 or 5 clicks away. It's 1 click away, right? So that matters as well. You're absolutely right. And we're going to move on, just maybe spend the next, this is fantastic, by the way. Thank you for all the questions. This is great. We want to sort of pivot and give a little bit of a slightly different example, and this on pediatric asthma. And this is more on the sort of call it a population size thing, and how do you actually take and manage individuals within a chronic condition that, if done right, can actually be much better managed. Just some statistics here, not only how prevalent, how big this problem is, but the other part that's really important, it disproportionately impacts minorities and low-income families. So it's even harder for low-income families, and the prevalence of it's even significantly higher in the Black population. And not only it's, we have a lot of kids with asthma. Many of you in the call might have a child that has asthma. One of the other just staggering statistics is that close to half are uncontrolled. And then, over 40% have an attack each year. There are a lot of people that actually die from asthma, so believe it or not. So that's directly. And it's something that can be preventable. If we're able to empower individuals, both clinicians and families, with the right information and alert them if something trends in the wrong direction, there are things that can be absolutely done and prevents that child needing to go to the emergency department or to be hospitalized. And that's been the goal here, is if we know somebody that has asthma, can we understand the risk of their asthma getting worse to a point that they require an emergency department or hospitalization, and do that 90 days before that event would happen? And there's a lot of literature, a lot of research put into why 90 days. It's just, it's the window where something can be done, and it's not too long. Still, somebody, hey, next year you might need to go to the emergency room. People don't pay attention to it. It's close enough that you can do something that has an impact, but it's not far enough that people just dismiss it. So it can be controlled, right? So that's the other key component. If we build an algorithm to predict a rising risk, can you do something about it? And, if you can do something about it, then kids stay in school. Families don't have to take their kids to the emergency department. So there are many other things other than, obviously the worst case where somebody actually dies, and that happens. So the objective here was, can we develop and implement a comprehensive data-driven, evidence-based quality improvement program that the core of it is a predictive algorithm that can alert both individuals and providers that a child is at high risk of their asthma getting worse if nothing's difference done, where they would require emergency department or a hospitalization, and then educate and inform and provide information to both the individual and the physicians to actually do something about it. So here's sort of a couple objectives. This I'm kind of, walking through a couple of these because I think it's important. And how do you go about it? How we went about it. One, is identify children with poorly controlled asthma. Great. Sort of build the data model to predict the risk of hospitalization or ED visits. Goal of this was, if we can identify who's at risk, support the trigger avoidance. So how do you actually develop an approach to continuously provide directly to the caregiver and that individual information? How do you, number three, timely alert the providers? So if the child comes to an office for, vaccination, if they're high risk of asthma, that pops up as a best practice alert that we talked about earlier, that has say, hey, talk to these parents about asthma, look into their medication, look into the inhaler, because do something about it, even though they're not here for asthma at that point. So this is a little bit of a schematic, here is, so there is a algorithm in the middle that produces the risk. So it takes the kids for asthma and categorizes into very high, medium, low. The individuals that are in a high risk approach about being enrolled in a text messaging program. So they receive additional information. They're being pinged periodically to understand, is their asthma getting worse or not? They're being ingested back. The providers, meaning the clinicians, including not only somebody like Parkland, but others in the community like FQHCs or others, receive alerts. Not only alerts, but they also receive a monthly list of, here are your patients that are part of your portfolio that, here's their risk. Because a patient might not be planning to come to the office over the next 90 days. So this is a way to also proactively be able to reach out to those individuals, even if they don't have a visit already planned. And then coordinate this community outreach with other partners, whether it's the county health department, the community-based organizations that actually have activities happening in the community. So, one of the key things that part of this is, I mentioned the texting program, because we want to be able to engage those individuals in a bi-directional conversation to be able to them take action or know what to do. We've built an app. We've built and customized Amazon Echo, the Alexa, to be able for asthma. What works best? Texting. So sometimes less technology, it's more. In this example, something less complex, it's easy. People don't have to download, particularly when we talk about communities that are underserved or more vulnerable. Texting works the best. But, kind of have the risk report, frontline community health workers or frontline staff context the individual to consent for them to enroll. Then they start to receiving text messages, and the different entities receive weekly report. And I'm listing a couple of key things that are important, how the text messaging works, but it's both the frequency of it, is the type of content, and having that short component, being bilingual, both in education and symptom monitoring twice a week via this. It's really important to be able to actually engage. Just like before, I wanted to sort of share some of the data sources and, what are the inclusion, exclusion criteria, the study period. This was, again, built between 2016 and 2019. The prospective model validation occurred for 2 years. So again, if you expect that you're going to have some of these models and in 6 months you're going to stand up and run with it, maybe you can for certain applications, but at least our experience is you need to be thoughtful. You need to put a lot of time to be able to make sure that these are done appropriately. These inclusion-exclusion criteria are really important to make sure that's being used within the population that you tested it and not used, off-label, so to speak. And this is a good example of multiple data sources required to be ingested, not only the EHR data, the social determinants of health data, the text messaging data that comes back, HIE data from in this case, the Dallas-Fort Worth Hospital Council and other data sources. So a lot goes into it. Talk a little bit the predictive model itself. Again, how it's done, how it's validated. Again, the goal is to be able to predict rising risk, and we're looking literally at that 90-day period. So for today, over the next 90 days, that's sort of the window that we're trying to predict. And then we go through a model evaluation every year. That is something that's really important to do, looking both at primary outcomes, looking at secondary outcomes, looking at the performance of the model. So this is something that's built and embedded. You saw it where we started with the full life cycle. And this is something that's really important to make sure not only does the model perform the way it does, are the actions that both individuals and the clinicians are taking are still relevant, and does it produce the results that you're hoping to see. For the previous one, you mentioned and asked about sort of impact. This one is much more straightforward to quantify. This case, about 4,600 individual patients rest stratify in this sort of in Dallas County. You see the number of unique patients that have been enrolled in the texting, and through these various activities, we're able to see is a 36% reduction in asthma-related emergency department visit. And this was matched to a control group. So this was sort of done where people didn't intervene, same medical complexity, same geography, same life challenges. So, long way of saying in a few numbers, it works and it can be done at scale. I included this for your review. I knew that we're not going to have enough time to go into it, but wanted to provide some information about the model performance. Again, sort of the rastrification, how many were in the very high and high categories out of those. And again, some of the parameters that ended up being towards the top of the model, as you kind of see some of the components here. One of the other things that I'll mention, and then try to pause to leave a few more things for questions, but it's one thing for the model to perform well, but one of the other thing is how well does the people that receive the information, how much do they value that? I think this is pretty remarkable because when, regularly serving patients is, close to 92% who recommend this to a family and friend. To me, that's probably one of the most impactful things, because if it's not useful, if it's not impactful, this is something that then it's not useful. And you see some of these other questions that we consistently ask and how, favorable some of these components are. I'm gonna be able to control the asthma better, but also just how do I, generally take better care of the health of my child. So this is an amplifying effect beyond the asthma itself. The last thing that I'll share is we wanted to put this information in the hands of the community, not just those that are high risk, but also people to be able to understand what does the asthma look like in my area where I live, and what are some of the things that are driving it, not just the medical conditions or the demographic mix of the people that are there, but some of the environmental things that I can become, with the group advocates about, or I can create awareness. So we built this pediatric asthma surveillance system. We actually made it publicly available on the Dallas County Health and Human Services website. So if you just Google Dallas County Health and Human Services and asthma, it will take you to the asthma page. And this is a active dynamic dashboard that you can play around with, both visually, and you can select the different indicators, direct and indirect, that you can start to see that impact. You can zoom in. This is done either the zip code or the census tract level. So you can put in an address, or you can zoom in a particular area, and you can see either at the indicator level or the overall asthma vulnerability gradient in quintiles. You see the colored gradients here at the bottom. What are some of the the prevalence, the risk of asthma in their community, what are the drivers behind it. So with that, I will pause and I'll leave you with these quotes. There are some of my favorites and how all this ties together. One is, this idea that, strategy without action is a daydream, and action without strategy is a nightmare. And I believe for anything effective, including what we talked today about AI, that you need to have both. But also that culture, to me, trumps strategy every day. Not that strategy is not important. You need to be able to have the right team, the processes in place, the people to make this work. And I strongly believe in this is where data analytics and AI comes to play, that they're the glue that actually links strategy to operations and to action. And without it, I think we're missing something. AI is able to bring that to new levels, to augment how we can use data and analytics, and it can supercharge our ability to use it and inform the decisions that we make better sense of the vast amount of information that we have available. So I'll pause here, Vishal. If there are any other couple more questions, we can certainly take those at this time.
Absolutely. There's a question, but I want to thank you for this wonderful presentation. You've received a lot of compliments, which I'm not going to read, but because in the interest of time, but I'm hopeful somebody will make the chat available to you.
Thank you.
And people are asking about slides, but I think this is somebody can handle. Like I think Michelle can make that available. I think the question there is, by the way. And I was going to come back. I was going to also emphasize that I've known Steve and the leadership team for a while. It is true. He's just walking the walk and not just talking the talk when it comes to culture trumps strategy. The question I have is, how can we manage the risks associated with the utilization of such decision support system, particularly the risk of clinicians becoming overly reliant on AI-driven tools and potentially neglecting patients who've been misdiagnosed?
Yeah, the goal of AI, again, at least the way it is at the stage that it is now, to me, it can save physicians time where they can actually spend more time with patients. To me, that's a good outcome of it, because if we can get physicians or clinicians to spend more time with patients and to be able to look that patient in the eye, interact, they're going to be able to use the information that's being, synthesized, organized, tee up for them in a way that makes that interaction even more meaningful. And that, I think, ultimately results in even better care. So again, I think the point where we are today, the future is bright. There's no question about it. I think this is a game-changing type of innovation and technology. But I think we need to be also very thoughtful about how it's being used, being thoughtful about the transparency behind it. And at this point, it's very powerful to be able to augment the decisions and support the decisions that clinicians and physicians make with the full transparency and their participation in it. So again, to me, ultimately, can we save time? And tee up information for them to consider that sometimes they might have seen already, or sometimes it's new, and spend more time with patients. If we do that, then this is useful, and it's done. You actually not only mitigate risk, you're actually able to even deliver better care to begin with.
Thanks, Steve. One last question, since all of us are faculty members in schools that range from operations research to industrial engineering to business schools. Any word of advice, as yourself being a PhD and you do research, you publish extensively as well, any word of advice or thoughts around what should us as researchers think about when we start addressing problems that are really powerful in terms of addressing inequities, outcome improvement, and so forth?
I think you just mentioned the word that I was gonna just within your statement, that I think it's one of the most critical one, and that's inequity. And the reason for that is, as you conducting new research, new study, developing new products, make a huge effort to have a very diverse population that you're trying to impact via that, and include the information data that's representative of the population that you're trying to impact and serve, including those that are oftentimes underserved. Because otherwise we're going to build and continue to build these things. And it's even more important for any type of data science or AI, because we want to make sure that we have information from all individuals, not just those that are easy for us to get to, or those that can and have the capability to do it. So that's my sort of my biggest just encouragement charge is embed equity into everything that you do, not just this extra thing that you do. And I think that way is going to just not only advance science, but advance what science comes up with in a way that's that much more applicable and useful.
This was great, Steve. Thank you for your time. I want to just leave with one last quote from Eric Topol at Scripps. People ask about AI and decision. He says, and you guys probably know this quote, he said, AI is not here to replace clinicians, but clinicians who use AI will replace the clinicians who don't. So with that note, I think we're a minute over the time. Thank you again. Thank you all for, thank you, Georgia and the practice platform leaders for organizing and giving us the opportunity. And Steve, thank you for your time.
Thank you so much. Thanks again for having me. This is lots of fun.
Okay. Thanks.
Thank you.